Hello, and welcome to the Child Neurology Foundation's 2021 Patient Advocacy Summit. We are happy that you are here with us. My name is Jessica Nickrand, and I support programs related to transitions of care here at CNF. This panel is called Why Should I Care What My Doctor is Getting Paid? How Advocating for Reimbursement for Clinicians Can Improve Transitions of Care. This is our inaugural Transition of Care Patient Advocacy Summit, and we believe that the patient voice and experience is an integral part of a successful transition from pediatric to adult care. This summit focuses on centering those voices and experiences, ensuring that these young adults and those who support them have the knowledge, tools, and confidence to be able to make the process successful. In addition to this summit, CNF offers other resources in the transition of care space, including a toolkit for young adults and their caregivers and their clinicians and healthcare providers to begin and encourage the many discussions required for a successful transfer to adult care. This toolkit is also available in Spanish. This and other resources in transitions of care are available at childneurologyfoundation.org/transitions. These resources and our summit would be impossible without our partners. We are able to put on summits like this for free today thanks to the generous support from our partners in transitions of care, Acadia, Biogen, ISci, Genentech, Greenwich, and Zogenix. Thank you. And we hope that if this session resonates with you, that if you learn something new, that if you find it helpful in advocating for yourself and you are able, that you think about making a donation to the Child Neurology Foundation. It would be very helpful in continuing our efforts to provide first-class programming and education like this summit to the entire child neurology community. Even $5 helps. So if you're interested and able to make a contribution, you can find out more online at childneurologyfoundation.org/donate-online. For that, we would be so grateful. All right, on to the panel. I'm thrilled to introduce you to our three esteemed panelists. Dr. Corwin Williams is a pediatric neurologist at Phoenix Children's Hospital, where he also serves as a clinical assistant professor in the Department of Pediatrics at the University of Arizona College of Medicine. Dr. Williams is the American Academy of Neurology liaison for ICD-10 coding and management and is the chair of the AAN Coding and Payment Policy Committee. Dr. Baca is the vice chair for clinical affairs and quality and chair of the epilepsy division at Virginia Commonwealth University. Previously, she served as an assistant professor at the University of Colorado Anschutz School of Medicine and trained at the Rochester School of Medicine, the University of California, Los Angeles, and was a Robert Wood Johnson Clinical Scholars Fellow. Dr. Baca is passionate about the need to evaluate and improve gaps in care for vulnerable populations, including those transitioning from pediatric to adult healthcare settings. In collaboration with partners from Children's Hospital of Colorado, she led efforts to develop pediatric to adult transition programs for patients with epilepsy. She is the co-chair of the Child Neurology Foundation's Transition Project Advisory Committee. Through research, education, quality improvement, and clinical care, Dr. Baca's mission is to evaluate and improve access to and quality of care for patients with neurologic disease and symptoms. Dr. Gautreaux specializes in child neurology at Children's Hospital, New Orleans. She attended medical school and completed her residency training at Louisiana State University, New Orleans, and she serves as an assistant professor of child neurology at LSU Health, New Orleans. She chose pediatric neurology because she finds the nervous system interesting, complex, and challenging. She enjoys the relationships that grow and develop with her patients and families, as many patients with neurologic conditions require long-term care. She's an active advocate for neurologists and their patients, and she participates on many committees at the American Academy of Neurology. With that, I would like to now pass it on to Dr. Williams.
Hello, everyone. Thank you for attending this summit about patient transitions from childhood to adulthood. I'm going to be talking to you a little bit about what this means and what this looks like from a physician and payer perspective. You're going to be hearing from some of my colleagues who are going to talk about their real life and real world experiences dealing with complex patient transitions from pediatric to adult providers. But one thing I think it's important to realize is doctors are people too. And that may sound like a truism. And I say that just because it's always interesting to me when I talk to non-physicians and how amazed and thankful they are when I say that I'm a pediatrician. And so I think people do appreciate physicians greatly, but sometimes don't always realize that physicians are humans too, and they get tired and overworked and angry. And that's obviously not your responsibility to deal with, but it's just something I want you to be aware of because it does play a little bit into some of the transitions. And the reason why I say that is that transitions can be complicated. There's a lot of information that needs to be transmitted. One provider may have been caring for a patient for many, many years and knows the family and patient intimately. And it's a question of how do you transmit that information to a new provider? Now, a lot of different methods can be considered, discussed. Sometimes it may just be a document that serves as that transition. Ideally, it would be great if the physicians could actually communicate with each other directly, whether telephonically, electronically, or even in person. And I believe that an in-person visit would be great and probably is the ideal way for a handoff to occur, with the possibility for the receiving provider to touch base with the previous provider. There's just certain realities that starts to bump against. And one thing I want to kind of highlight in this brief section, which I'm talking with you, are some of those realities. So as physicians, we are on a very basic level, workers. And many of us work for organizations who employ us, and they have certain expectations about our level of productivity. That productivity is typically measured in patient contacts for which we generate charges or bills or office visits. And work that's done outside of that is often does not generate revenue. And at the end of the day, at the end of the month, at the end of the year, institutions particularly, but even small groups, have to look at their revenue, because this is how practices stay open. This is how hospitals operate. This is how they pay salaries, not just for physicians, but also for nurses and administrative assistants. So hospitals are very focused on documented productivity, and that often is based on what type of charges are placed. So that's important for you to understand as a family when you are looking for assistance with the transitioning process, because when you are asking for things that are not necessarily recognized as revenue generating, they often are not supported by the practice, by the institution, and oftentimes by the physician. Physician providers have many responsibilities. They have many patients to see. There are many other tasks they have as far as leadership within their organization. They have other tasks such as writing letters, refilling prescriptions, writing notes, signing orders coming from outside facilities. Those two often are not reimbursed as well, but those are really required as far as the practice of medicine. So specifically, what I would suggest is to kind of consider how a physician's time is reimbursed, and seeking support from your provider in the transition process by working within some of those reimbursement situations. Currently, one way that providers are consistently reimbursed is their time on the date that they actually see a patient. So what does that mean? So if you spend 10 minutes with a patient, you're reimbursed at a certain level. If you're spending 30 minutes with a patient on the date of the encounter, that's reimbursed at a certain level, and so on. So one thing I would say that could be useful for families is to think about what they need from their provider on the date of the encounter, and bringing that set of requests or ask and trying to get that done on the date of the encounter, because that's a fairly straightforward way in which providers can be reimbursed and they can document their productivity. Now, what that would mean on the part of the family is that you have to be proactive and think about what those asks are. So a good example of that is I see a patient of mine for epilepsy, and we need to talk about the epilepsy, what's going on with the epilepsy, other medical issues. But if they also say, we also need to have some paperwork completed by you as the physician for guardianship, would you be able to complete that? That's wonderful, because I can do that in the context of the visit or on the day of the encounter, and my time spent on those tasks on that patient's behalf would be counted. Now, if I saw them in the office and they said, oh, by the way, I have this paperwork I need you to complete. I don't have it with me, but I'll get it to you in the next couple of weeks. I'm certainly going to try and get that paperwork done for them. But at the same time, my time is not being reimbursed for working on that particular issue if I'm not doing it on the date that I meet a patient. So one thing I just want to leave in your head is that time that you spend on the day-to-day encounter with your provider is time that they can use, and then they can document their productivity. Now, that when our current regimen is probably the most consistently available way of providers for documenting their time. Now, I will say that there are some other ways that providers can document their time and work on behalf of the patient. One of the challenges that we have in medicine, though, is that sometimes, even though these codes exist, they may not be available to every provider. Let me give you an example. There is a code that's been approved by the federal government for something called principal care management. That means if you as a provider are taking care of a condition that is ongoing, chronic, and requires a lot of effort and care planning, that you can bill a particular code even on a month-to-month basis using the assistance of, say, nurses or dietitians within your group for work that you do on behalf of the patient. And in this particular example, if you spend more than 20 or 30 minutes working on care for this patient in the course of a month, then that can generate a productivity equivalent. The challenge with this code is that even though it's been approved by the federal government, there are payers who do not recognize this code and do not pay for this code. So what does that mean? So say, for instance, that I have a patient who contacts the office, several times over the course of the month because there's some issues with, once again, their epilepsy management, or we need help with prior authorizations, and my nursing staff is working with that, or we needed to send orders to a home health care company, or we needed to triage an issue going on with an infusion center. That staff time, that office work would not be recognized. An example that I can share with you is that I have a particular payer here where I am who is a pediatric payer, and they have just said across the board, we don't recognize that code and we're not going to pay for it. So that creates a disincentive for providers to be able to devote time to that particular issue, in part because that work is not being recognized. And yet it does take resources of the office to do it. So that's one particular example. That's time that could be used to help with transition, creating transition documents and speaking with other healthcare providers. That's not recognized. Another particular example of a code that exists but is not necessarily paid for by particular providers would be a situation in which you could have a telephonic conversation between one pediatric provider and an adult provider to review a record and to share thoughts and recommendations that you may have that may not be fully documented in the record. Once again, it's a code that exists but isn't always covered. Another one would be in which providers could actually provide essentially office visit services, but to do that digitally. So not through video conferencing, but essentially through electronic communications. That could be helpful as families begin to transition from one provider to a different provider. But once again, it's the sort of work that is not often recognized. Now, currently during this pandemic, and as I record this in 2021, there's still a national health emergency in place. And so certain rules regarding the ability to speak to families by telephone and to be reimbursed for that exist. Now, I'm not sure that that will persist beyond the national health emergency. Congress will have to act to change some of those rules. But once again, that could serve as another useful tool in helping a family transition from one provider to another. And for right now, we can make use of that. But after the pandemic, that might not be available. And so once again, we have something that requires work, requires time, requires effort, and yet is not being reimbursed. And unfortunately, with just about any situation in adult life, there are certain incentives to perform work, certain things that allow you to perform certain functions on behalf of patients, but if they're not being reimbursed, you often find that those services slowly disappear or just not even offered. So I hope this has not been too meandering of a discussion about how physicians work within the healthcare system. But ultimately, physicians provide cognitive expertise, and their work is often recognized through the use of certain billing codes. These billing codes have certain rules around them, and institutions for which physicians work, whether it's private practice or whether it's a hospital system or a larger enterprise, really require physicians to be, as they describe it, productive. And that productivity is measured through these codes. So as a family, that's not necessarily your responsibility, but as a family looking for assistance from a provider, it's very helpful if you recognize how you can help the physician utilize their productivity most effectively for you. And I would suggest, and hopefully you'll hear more of this from my colleagues, I suggest that learning to have these discussions on the day-to-day encounter, coming prepared to the encounter with your list of questions and ask, so that that time can be used most efficiently for everyone involved. So I want to thank you for your attention. We certainly need your support and help as we try and make some of the changes in the healthcare system that work for everyone. But certainly if you could help make the case as to why transition care is important, why chronic care management is important, why non-face-to-face services are important for transitioning and for the overall health of your children, that would be fantastic. So thank you again.
So now we're joined by Dr. Baca, who is an adult epileptologist, and Dr. Gautreaux, who is a child neurologist, and they're going to share with us what some of the challenges and progress is in this particular area and how we as caregivers and their advocates and young adults can get involved in this particular work. So Dr. Baca, can you share with us how, what some of these challenges and struggles are for you in transition of care?
Thank you, Jessica. Pleasure to be here. Yeah, I think if I were to say in a nutshell what the main problem is, it's time. And we, a lot of the patients that we see are wonderful to see as they enter the adult world, and it's such a privilege to be involved in their care and work with their families. At the same time, they have a lot of complex needs and a complex history that has accompanied them, all through childhood for some of them, and then entering the adult world. And then to think that we can kind of, as the adult neurologists, all of a sudden have everything tied up in a bow with one visit is obviously a little bit unrealistic. To that end, we need time. We need time to make relationships. We need time to make the transition, and we need time to talk with our pediatric partners who have been sending our patients to the adult world, and that team to really make sure that we're understanding the patient's trajectory as they enter the adult world so that we can optimally take care of the patient and the family. And, one of the things that has been frustrating for many adult neurologists, and I would imagine for pediatric neurologists too, is that, oftentimes we've conceptualized this optimal model whereby what if we could see the patient together, in one visit on the same day, and then maybe some of this complexity would be less complex because that person who's been caring for that patient and for whom the patient has a relationship, one sees that they trust me in my case, or another one of my colleagues, they have trust in me to, take the baton and move forward. But also to kind of verbally go over things with the patient in real time to make sure we're understanding the medical history and everything is transpired. And to have that real-time interaction has been very complex from what we call kind of time, money, coding, reimbursement standpoint. So in very kind of black and white terms, if I am an adult neurologist, which I am, and I have a colleague of mine who is a pediatric epileptologist, if we see a patient on the same day for the same problem at the same time, only one of us can submit a code to the insurance company that will then potentially be reimbursed. We can't both do that. That would be fraudulent. And so that means that one of us can get paid. And at the end of the day, we both need to be paid for our services so that our institution can support us and we can have all the resources we need to take care of the patient. And so that has been frustrating in that sometimes that is not understood by institutions to kind of even describe this type of conversation. In fact, I remember calling some of the coders in institutions saying, "Hi, I want to develop this clinic. Can you help me understand how to do it?" And they didn't even know what I was talking about. And so then we had more meetings and they still didn't know what we were talking about. And then ultimately we kind of got to the nuts and bolts that we were coding for the same thing, or from their viewpoint, the same thing. But we were trying to articulate that there's a pediatric expertise and adult expertise for the same problem, and that wasn't really being recognized. And so then what happens is there's an issue of how do we build something that's optimal when there basically are not funds to do it in our current healthcare system. And so where do the funds come from? And the funds often come from, getting a grant somewhere, philanthropy or other resources, or kind of institutional buy-in for a program. And ultimately, in order to make something sustainable, that usually is still contingent upon a situation where the health system is funding it long-term because grant money can run out, et cetera. So that has been one of the frustrations, I think, in the field for a lot of people, is that we have a lot of great ideas. And sometimes we actually have clinics and then we run out of funding because the grant runs out and then we can't continue it. And this is what we think as physicians is optimal care for our patients, and that many patients have voiced, to us and their families that this is what they would want. And to feel like you can't deliver that because of this issue is honestly, it can be heartbreaking at times to feel that you can't do what's ultimate or optimal and appropriate for your patients. So I don't know. I love taking care of patients as we transition them, but I do admit that there's that frustration in terms of developing sustainable models of care from a financial standpoint. Jessica, Dr. Cottrell, please tell me a little bit more about what you think about the, funding models we have and what that means for your time or other colleagues' time, and if you can think of ways that, we can move the field forward.
So I think that you bring up a great point, that the ideal situation would be to have a face-to-face meeting where everyone's reimbursed appropriately. And right now, with us being in a fee-for-service model from CMS and the government of how we get reimbursed, that's going to be difficult to make happen. But I do think that advocating or patients getting involved and putting out their stories and pushing for thinking about the way we pay physicians or pay for medical care differently is a huge area for advocacy. And that's going to be a place where patients can get involved, is supporting these new ideas that come up, such as maybe instead of fee for service, prioritizing transition. And then there's a fee for this transition care or some kind of incentive for transition care as opposed to fee for service. But I will say that while we are in this fee-for-service model, we've made some progress, especially with advocacy, and actually improving things, in my opinion, for transition. So as you mentioned, because we can't be face-to-face, getting everything together to make a smooth transition takes a lot of time. So from my end, from the pediatric provider, you want to summarize this relationship and all of this care that you've had for years, whether that be in a document or making sure that everything's in one place, from old medical records, old imaging, treatment plans, so that things aren't reproduced or redone that don't need to be done. You want to compile all that. On the side of the adult provider, they need the time to review all of those things. You also need to be communicating, where are you going for this care? Where are you transitioning this care? And that could be on the peds or the adult side. That's probably outside of an appointment. So I do think we've made some progress from an advocacy standpoint in getting CMS to change the way we think about paying doctors who are cognitive specialists. So surgeons may get paid, for example, for a procedure they perform, but neurologists, being cognitive specialists, or those doctors who are thinking and coordinating your care, that was not always paid in the same way. But if you guys may recall, about a year or two ago, there was kind of a national outcry about protecting time with patients. They were going to cut back on how they paid doctors who thought. They were going to say that, kind of all of the levels of patient care were equal, and groups like the AAN, the American Academy of Neurology, and other patient groups, went out and said, this isn't going to work. If doctors aren't paid well for their time, they're not going to be able to give good quality care to patients. And people started advocating for CMS to rethink the way they paid cognitive specialists. And so what happened in 2021 is they actually changed the coding and the way that codes are given for each visit. So for a little background for those listening today, when you go and see your physician, it used to exist that when you went to the clinic, your doctor was able to bill for the amount of time that they spent with you face to face. So meaning the time they were in the room with you, and that was really all that counted for that doctor. If they then left the room and had to review records or needed to compile records and send a summary letter to your adult provider as you transition, for example, that was not reimbursable. And so that made it tough for hospital systems to support that, because there wasn't a way for these doctors to get reimbursed for the work that they were doing. But with the changes that have come up recently, doctors are now paid not only for the time that they spend in the room with you, and the hospital's reimbursed for the time that the doctor or the physician's in the room with you, but also for the time outside of that room, as long as it happens within the day that you are seen. And so this is a huge win for transition of care, because now, even though you may spend a long time face-to-face with your pediatric neurologist and tell them where you want to go for your adult care, when you leave, now they can sit down and pull all of your history together. They can type up a summary document. They can call the adult provider's office. They can call other places where you're going to receive services. And now that is all reimbursable, because that is that doctor's time doing work. And on the other end of that, the adult provider where you're transitioning, when they need to sit down and review your records and look at your old imaging and look at all the medications that you've used before, for them now, that is also reimbursable. So I think from a transition standpoint, this change in E&M is huge. It's really, really helpful. They've also added codes now so that if you communicate with your providers by MyChart, for example, so if you send messages, that's now got a billable code. It doesn't mean that it's reimbursed by all payers yet, but at least CMS is now thinking about creating these codes that are out there to recognize that this is work that's being done. And eventually the hope is that these codes will be reimbursed well and that payers will cover these while we're still in a fee-for-service model. There's now codes for telephone communications. There's, if you saw an adult provider, for example, and that adult provider then wanted to consult back by phone with your pediatric neurologist, there's now a code for that. That interplay or that interaction that didn't exist before. Again, not always reimbursable, but the codes are there. So people are starting to think about ways to compensate and to make sure that this is considered of value, because it would be hard for your hospital system or for your practice to support something that's not reimbursable, that's not generating any revenue, unfortunately. You know, when there's not revenue, they're pushing for you to see more patients. So they want you to do things, they want you to be compensated for all the work that you're doing so that the system can be sustained. And like you mentioned, that these types of clinics can continue, that they have a good fee stream, unfortunately. So I think we've made some progress, and the way that was done was by doctors and the American Academy of Neurology and AMA and all kinds of different groups getting out there and advocating for a look at these codes and to revise them, because that hadn't been done for many, many years. So I think moving forward, patients and their families really could get involved with these groups like the AAN when an issue like this arises. There are specific disease groups. So like for example, headache disorders has their own advocacy group that goes to Washington once a year. And that exists for possibly epilepsy, I'm sure. And I think there's a stroke group that goes. So there are multiple other groups that when they travel to advocate, they bring patients with them. And you can actually get face-to-face with your Congress members and tell your story and why these issues are really important to you. And so it may not have been that when we were advocating for time with patients that every single person going had a transition story, but if one person did, that would be a great story to share about gaps in your care or something that may have happened or your struggles, so that they can really understand how these decisions, something about time that's hard to wrap your mind around when you're on the congressional side, but how time really trickles down and impacts patients. You have to go and give them a clinical example of that for them to see why they need to make changes. So I think we're moving in the right direction of at least making transition easier in this fee-for-service model. But I do think that, as you mentioned, ultimately the idea may need to change into other models of care that would make transition even easier. And I think that's what you want to have on this group's radar so that they'll be aware when those issues come up to jump in and get involved.
Yeah, no, I think you make some excellent points, and you're right. We have definitely moved the field forward, and it doesn't happen overnight, right? You sometimes have to push hard for a long while before things can move forward. And kind of baby steps gradually then amount to many steps moving forward. And so I totally agree that this notion of kind of non-face-to-face time, which does sound kind of funny, admittedly, but being kind of valued for all the work that takes place beyond kind of that moment when you're with the patient. And patients know that we spend time with them outside of clinic, addressing phone calls and messages, and they want to support that, I would imagine, in terms of our time. That is very important and definitely a step forward. So, I think about all the members of the team in terms of kind of the transitions and the implications that could have for other members of the team as well, beyond the physicians. And I think one of the things that I'm just thinking about is when we see our patients and understanding, how we code things and what's reimbursed based on the coding may feel very removed to the patient experience. But I think what we're trying to say is it's intrinsically showing the value of what we're, their care a little bit in terms of what the system is valuing for their care and what they put into it. And so we've moved the field forward for transition a little bit. We still can move it forward more. And that was kind of with a big team effort that involved physicians and patient advocacy, et cetera. And so their voice for our time, and that value is really, really important, I think, is what part of what we're trying to say. I mean, there's all this stuff that goes behind the scenes that, that a hospital has to be maintained in terms of those resources. And so money pays for lots of different things and has many implications for the system.
And if you think about it too, when you're doing transition of care, there's likely a nurse or a clinic coordinator or a social worker or someone who's helping you with coordination. There may be other members of the staff who are part of the multidisciplinary clinic. There are now codes that recognize that some of this work is done by, the term is other qualified health professionals who are non-physicians. And now there are actually codes that can be used as part of transition of care that recognizes that they may do counseling with you, or they may do care coordination by phone, or even face-to-face in helping you as you move to other clinics. And this is not transition specific. This applies really to any medical care, but it's actually great for transition because there is so much involved and there are a lot of hands in there working. So it's great that not only, like you mentioned, physician time is being recognized, but they're actually creating codes for some of the other people who are involved. And again, recognizing that all of these people are doing valuable things And it should be, the hospital or the system should be compensated for it. Again, shows that it's valuable, the work that you're doing. So.
Yeah, I mean, transition's a team sport is how I look at it, right? It can't do it alone. It intrinsically involves, for example, you sending a patient to me, but there's so many other people involved in that process to make sure that the patient and the family are getting the care that they need and is appropriate. And so I'm wondering, I've been reflecting as we've been talking a little bit about the codes that actually, the non-face-to-face and kind of maybe paying for people services and time that are beyond just the physician. Sometimes when we think about transition work, the adult side of things is always kind of labeled as a little bit cold and not as team-oriented and that kind of thing from the pediatric perspective. I'm wondering if there's an opportunity for these codes to help with more team engagement on the adult side. Is a very maybe extrapolation of all of this. I don't know.
No, I absolutely think so, because I do think there is the presence of more multidisciplinary clinic on the ped side, and our patients find when they go to the adult side that things are pieced out more. And I think because you don't have that central home as much, it doesn't feel quite the same. It's not necessarily cold. It's just that when you go here and then you go here and then you go here, you don't get that every time you walk in, everybody here knows me kind of feeling in one spot. So I do think you're right. If y'all can, or if those codes could be used to build more of a group face, it probably would feel a little bit more welcoming, I think, on the patient side. Yeah, they would love it, I'm sure.
Yeah. Do you, what is your thought about kind of how people understand these codes in terms of, their utilization right now, particularly as it pertains to transition? I mean, these codes, these modifications are still in the grand scheme of things very new.
Very new.
And new just to use, period, independent of the transition concept. And so I'm wondering what you think about dissemination for them and utilization when we're specifically talking about transition, and what maybe we can do to help that process more in terms of education and whatnot.
Yeah. So I think it's I think you're bringing up a huge point on in the whole system, is that there are so many codes and so many ways that we've tried to recognize all the work that people are doing, that when you're the one who's coding, when you're billing, people don't always know what's available to them. So you may actually be running a clinic model right now where you're doing some of these things and not recognizing that now in the last year or two, this is something that you can bill for, or that can be reimbursed, or that is even now recognized as work. And so I think, as you make these changes, you then hit the next kind of block in the road, which is disseminating and educating everyone that this now exists and how to use it. And if you think about the new codes that came out January 1st of this year, I mean, these were huge hospital-wide education programs to teach people the basics of how to use it, much less when you start, and that's just them, one-on-one with their patients in their clinic, they've been doing every day for years. When you start trying to apply these codes to these bigger, more complex clinics, or these newer ideas and newer models, I'm sure there's many places where they're not being utilized, and there's probably a lot of education that can be done. And that's a challenge. How do you do that? I mean, it's another expense then to try to educate everyone how to use the codes correctly. And not everyone has time to sit in long courses. I mean, because this can get really detailed. I mean, some of the codes you have to carry around, little charts in your pockets to understand exactly how to apply them and use them. That's us as the providers. So, I mean, getting people to be able to break it down in the day-to-day can be very difficult. And I mean, I work on a committee where this is the stuff we talk about all the time. I'm on an AAN committee where we're talking about codes. And so I'm hearing this, and I still have to look up stuff. And I had to look up stuff even to kind of get my mind around everything I wanted to talk about, as we met tonight. Like, what are some of the new codes and how do things apply? Have I been doing them right, or are we doing those correctly? And you have to constantly refresh and relearn, and every time they make a change. And even when you've been using them every day, sometimes you have to look back and get the details. So we're saying this kind of in these bucket terms, but then applying all of the changes is not always very simple either. And I can imagine if we started to try to get away from this idea of these types of codes and fee for service and move to these even grander models, there'll be a huge learning curve at that time as well. So, all, like you mentioned, baby steps. It is all baby steps, because all of these changes, once you have the novel idea and you've made the progress, you've then got to work with implementing it and making it, day to day for everyone. So
yeah.
lots of blocks along the
I mean,
road.
I'm just reflecting now upon, being a medical student and trying to learn anatomy and trying to learn the medicines. And now I thought, okay, I'll have to keep up on certain things in my field. If you had asked me back then if I would be doing a webinar about coding and reimbursement and why that was important, I would have not known what you were talking about.
Right.
And two, it is a whole nother skill set now in a whole nother area of knowledge, which is daunting sometimes. I mean, there's a lot, that we are trying to do as physicians or providers to take care of our patients and make sure we're doing everything right medically. And so I think one of the things that is really also challenging is not only the time for making sure that it's being coded and reimbursed so that it's valuable in our healthcare system ultimately for our patients, but this is time, you don't just know this, you have to learn it, and it takes practice, and that in itself is time, and the expectations are quite high that you just suddenly know it.
Right.
And so I guess.
Yeah. I will say the AAP has done a good job of keeping up. So the AAP almost every year, I think, puts out their transition document on what the code changes have been and how you can use them in transition. And they give some clinical vignettes that physicians can use for examples of how to code all of these codes. Some of the ones I was speaking about earlier, the electronic medical record communication, the telephone, how you can apply those to actual clinical visits. So I think, some of the bigger organizations are recognizing that it's not easy to put all this together, and they're putting out these summary documents. And that might be something that, neurology needs to think about, whether that be, from a child neurology side or adult neurology side or some kind of collaborative thing. How can we apply those codes to our transition of care? Because that's a very useful document. But when I say summary, you still have, it's 30 pages. The summary of how to use the codes is 30 pages, and it probably gets a little longer every year with the updates. So it's not an easy task, no matter what, it's just not an easy task. But it's nice to see the summary document showing the progress that we're making every year. Because I was looking at 2020 versus 2021 even. Not long ago, and recognizing what was there and how useful it was. So there's certainly some good news.
Yeah, no, and a lot of AN has done a great job. CNF, it's thinking about how to educate people in this realm, because it really is important, and to do it in a way that's kind of sensible, that makes sense with, okay, here you are in clinic, this is what you do in the moment, to make it really kind of real. I do think that is one of our challenges, and we're and opportunities, and we're trying to do things like this to try to make it more comprehensible to people and understand the value in it. So I think that's great. I'm wondering what given the progress that's been made, and going back to kind of what I talked about in the beginning, where kind of the feeling of frustration that you can't do still the ideal state. What do you think about kind of, will we get to a place where we can value that ideal state, and doctors and patients can have more of a voice in that process? I know I'm asking you an impossible question, but I'm just wondering what you think about that.
Well, I think that there's certainly more people on both ends recognizing that fee-for-service may not be the best way to practice medicine. So bundled payments or, outcome measures as the way to reimburse, or recognizing points of care like transition or preventative care and paying for that a little bit different. So I think as different payment models are brought up, which is going to happen at some point, right? I think that's definitely which way we're moving. I think it's up to us as physicians, and then also something that should be on the radar for patients, to pay attention to the pros and cons that you hear, and try to get behind and put your support behind those models that look like they're going to benefit, patients the most and patient care the most. And I think by aligning yourself, as the people who are here listening today, if you align yourself with your disease-specific advocacy groups or with big groups, follow the AAN, on social media, they tend to put things out there when something's coming up from a legislative standpoint. This is starting to be discussed, or this is out there, and they tell you ways that you can make sure that your message is heard. Number one, they usually provide some education on it, but two, then they'll say, okay, this is going up today, email your congressman, email your representatives, and they tell you, it's going to the House or it's going to the Senate, and they tell you to send this letter. So I think kind of tuning in on some of the big advocacy groups and paying attention as these topics come up would be very beneficial. And I think that's kind of the only way we get there is, I don't know that the people on the other side, when I say that, I mean those passing the legislation, see things from our perspective. So I think it has to come from those people who are in the medical field and then the patients themselves telling their stories and trying to get their message out there about their care to really make change. And I think that's what's happened over time. It just, as you mentioned, takes time,
Yeah.
So,
Do you ever personally have conversations with patients, and families about topics as it pertains to this and just to visit, like it just comes up so they understand that you're all kind of on the same page about the context of all of this?
So yeah, it comes up sometimes. So I'm a child neurologist, but I'm also a headache specialist. And so that's where it comes up most often for me, is there patients with headache diseases run into some just boundaries in general, not necessarily with transition of care, but just in general. And like I mentioned, there are advocacy groups for headache diseases that visit the Hill and bring patients. So yes, I have talked to patients about, considering joining the group, considering being willing to travel DC and share their stories. But if not, then, writing their congressman, because it comes up. It's just things that sometimes you discuss in clinic. And then also a lot of doctors have, professional social media. So you can follow your own physician online and kind of see, especially if they're doctors who are involved in advocacy, you can see when topics that are specific to your disease process come up because it's your own physician that's out there sharing it. So you can follow their social media streams. So even if you're not having that conversation in clinic, you're having that conversation at the broader sense about what's coming up on the horizon that might be important for you to get involved in. So yeah, I think if we put the message, I think I'm putting the message out there and people are interested and engaged in it for sure. I had a patient recently, she was a senior and she was going to go and teach her class about migraine and what was going on, so that's like advocacy at the very, basic level is, even children and even, teenagers and adolescents can advocate by just spreading awareness of their disease process. And then once you have your disease process on someone's radar, then you can start pushing for what you need to, receive better care for that or to remove barriers for you. Because some people just don't even know about specific diseases. So we can all be advocates no matter how old we are, just by educating.
Yeah, definitely can do things on a one-to-one level in our kind of clinic and engagement, and then make it bigger through different kind of more broad, strategic advocacy initiatives for sure.
And do you guys see, for us, we usually have parent and patient in the room. So I feel like sometimes there's a lot more advocacy because they're advocating at school. Parents have to be advocates, but I don't, from the adult side, if you guys find patients.
Yeah, it depends. It's always, I think a little bit on a case-by-case situation. It depends on the given patient and obviously their level of, cognitive, functioning given a given disease state. For example, I have a lot of patients who need a parent in the room as they can't take care of themselves as physiologic adults. And then I have patients who, in addition to the transition in healthcare, are transitioning from kind of teenage to young adult years, and kind of you need sometimes the parents there, but then not there at the same time to really start building their independence and helping them form their own voice. And so I think it's a mixture. It depends on the patient population. It can be intentionally with or without, sometimes depending upon where you are with your relationship and the patient's needs. So I think there's opportunities, for those discussions in those realms, and those discussions may look, a little bit different in terms of the meaning of it for a given patient in the population to understand kind of what the needs are and what the background is. But I still think all of these things in those moments, even that clinic setting, to kind of paint the picture of this framework that, being valued for the time actually allows us to provide the care that they need, which is kind of the ultimate message, right? And that sometimes these things may seem very far removed from them. Like, we're not talking about their medicines or their physical therapy or whatever the case may be. We're talking to bring up coding or insurance, they can often relate to insurance issues. And so there's often a way to build in the discussion there to kind of help on a grassroots level, kind of broaden our understanding and have these conversations about the value more broadly. So yeah.
Yeah. And I think everyone's done it. Everyone's advocated for something about their medical care before. And, whether that be that you need medicine at school or you need your insurance to pay for a certain medication, every patient or parent has had to advocate for something before. And so if they become, like you said, kind of more aware of these broader issues, they will recognize then that if they go and advocate for that, it actually trickles down into better care, long term. So you've done it before. If you just get that background understanding of these issues, then you can go and do exactly what you did with the school principal or with that person at the insurance, but on a grander scale, and it really has a big impact. So.
Yeah.
And that will conclude our panel today. Thank you so much to our panelists, Dr. Williams, Dr. Gautreaux, and Dr. Baca. On behalf of CNF and our communities, we are so grateful you have all shared with us your time and expertise, and we look forward to implementing what we learned. As a reminder, CNF and our partners have more resources and transitions of care available both at childneurologyfoundation.org/transitions and also on the Password Protected Hub where you accessed this talk. We'd like to again thank our partners, Acadia, Biogen, iSci, Genentech, Greenwich, and Zogenix. And we invite you again to help fund our programming if you're able to do so, because the greatest feedback you could give, the greatest gift you could give us if you found this session helpful is a donation. So please go to childneurologyfoundation.org/donate-online. Thanks again for joining us, and be sure to check out the rest of the talks available on the Summit website.